So yes, I've been telling you how good clozapine is, but now it's time to tell you the not so good side of clozapine. In this video, we're going to talk about all things clozapine, an incredible drug with some side effects we need to know about. Very complex drug, so let's get into it. So the outline of this video will have 5 parts. The first is a bit of a patient story to give you an example of how you commonly see clozapine being used. The second is we'll talk just a touch about the history of clozapine because it's pretty interesting, given the fact that it was actually taken off the market at one point. We'll talk about the indications for its use, the chemistry and the pharmacology around how it works, or at least how we think it works. You know, there's still a lot to be discovered about the human brain. And finally, the most important thing for patients and people who are educating people around clozapine, the most important thing to know is the side effects and the monitoring requirements for those side effects. A quick note, this will probably be at a level of maybe a senior medical student / junior doctor, but I will try and make it useful for everyone, even if you're not in the medical field or not a medical professional. So with that being said, let's get into it. So let's start with a bit of a patient story. This is kind of made up an amalgamation of different patients I've seen over the years that kind of give an example of how good clozapine is. So let's just call this guy Mr. AB. He's 40 and has a diagnosis of schizophrenia when he was 20 years old. When he was 20, he was found wandering a skate park at 2 a.m. in the morning, completely disorganized. This is after months and months of socially being withdrawn from his family and friends. And police picked him up and he just made no sense when he was speaking, which is what we call loosening of associations. It's an example of disordered thought form, which is a sign of psychosis. And he was diagnosed with his first episode psychosis. Since then, he had tried, after that, olanzapine, aripiprazole, combinations of antipsychotics, and nothing really worked for him. He kept coming back to hospital with disorganized thought and saying things that didn't make sense, and sometimes behaving dangerously, like punching walls or running on the streets in the middle of the night and into traffic. So it can be really dangerous being psychotic, obviously. So finally, he goes into hospital and they start him on clozapine because one of the indications, which we will go through, is treatment-resistant schizophrenia. And because he had recurrent psychosis, he had accrued the diagnosis of schizophrenia. But once he started clozapine, ever since he started clozapine, he hadn't gone back to hospital. Ever since, it worked really, really well. It's the best he's ever been. Then 6 years later, he developed something called neutropenia, which is one of the side effects we're going to talk about, and had to stop clozapine. All right, let's stop the patient story there and talk about clozapine. So over the past week, I had to give a presentation and I had to go through a lot of different papers to talk about clozapine. But part of it is I learned a bit about the history, which was very interesting. It was discovered by Wonder Pharmaceuticals in the 50s, and it was kind of brought onto the market 60s and 70s, and it was working really, really well. But then they kind of noticed people dying from something called agranulocytosis, which is essentially when a specific type of white blood cell, so as a little bit of a memory jogger, your blood is got water, proteins, fats, and cells in it, and it's got red blood cells and white blood cells. Red blood cells do the oxygen, white blood cells do the immune system defense. There are lots of different types of white blood cells, but they can be kind of grouped into the agranulocytes and the granulocytes, and the differentiation is actually completely based off microscopy and how they look under a microscope, not based on function. But the granulocytes are the things that look like they have granules, like stones or dots under a microscope, and one of those, there's like 3 or 4 granulocytes, but one of them is the neutrophil, and this is the cell that gets affected by clozapine in a very small percentage of people, less than 1%, and unfortunately, in Finland, they found 9 people who died because they lacked this white blood cell. And obviously, if you don't have that white blood cell, you're immunocompromised, right? It's an immune cell. So if you don't have it, you're immunocompromised. And these people were dying from infections. So the whole entire world, except for like poor countries that didn't really have strict monitoring requirements. So developing countries such as India were kept using clozapine, but most of the entire world pulled clozapine off of the market because of the risks. And then they had no clozapine for a decade, and everyone was pretty unwell. There was so many people that just were not responding to any other psychotics. And so in the 90s, there was a couple of studies that just showed how effective clozapine is over the alternatives like chlorpromazine. There was a big study by Kane et al. And so it was reintroduced, but you had to do very strict monitoring so that you wouldn't get the agranulocytosis. It was to kind of pick up on agranulocytosis before you got the symptoms of an infection, and then you would become really unwell. So with the monitoring, it reduced the incidence and the death rate, or the morbidity, the illness rate of getting sick with agranulocytosis substantially. And ever since, it's been a wonderful drug. But there's so much variability in the world. Like, there are some countries that are so, I mean, I got to say it, they're scared of using it unfairly. The percentage of people who have schizophrenia who are on clozapine ranges from like 4% in the United States to like 40% in other countries like Australia. So that's a bit about the history. Now let's talk a bit about the indication. Why would people ever need to use clozapine? Well, the kind of agreed upon international indication, because there are differences in different countries for when they use clozapine, but the one thing that all countries agree upon is that it's useful in treatment-resistant schizophrenia. Okay, so it's when you have a chronic psychotic illness that isn't responding to the other antipsychotics. And just to give you an example of how effective it is, I just will quote this paper. Despite non-response to other antipsychotics, the chance of responding to clozapine is more than 60%. So that is saying that if you have failed 2 other antipsychotics with a chronic psychotic illness, you have a 2 out of 3 chance of having some response with clozapine, and half of those will have a substantially positive response. So it's a very freaking effective medicine. Now, there are other indications for clozapine, and it's always treatment resistant. So treatment resistant mania, you can use clozapine. It's useful for people who are very suicidal with their illness because it's got evidence to suggest that it reduces suicide, especially in psychotic illness. It also reduces violence, so people who are very violent and behaviorally aggressive. So, for example, it's in some countries, it's actually indicated for autism spectrum disorder, for people who suffer from autism who are just so unwell that they get violent. And then the final indication as well, which kind of falls under psychosis/mood, is psychotic depression. So people who are so depressed that they've actually developed a psychosis. Now, in terms of how it works, the pharmacology. Now, don't click away if you don't understand any of this stuff, because if you're a patient or a caregiver, you need to listen to the next part, which is the monitoring and the side effects. But in terms of how it works, look, it's incompletely understood. We know which receptors it binds to, which is very interesting, but it's kind of unexpected that it works as well as it does based on those receptors. Because what we expect is, if people are really psychotic, that when you block a receptor called the D2 receptor, it reduces the psychosis. But what we see with clozapine is that it actually doesn't bind that strongly to that receptor. It seems to do this other thing, though. It seems to bind on and off, like a hit and run mechanism, where it binds and like it binds and releases really, really quickly. So that might be how it has its effect. But it binds stronger to the D1 and the D4 receptors, and not even only on the D receptors, which stand for dopamine receptors, but it also blocks serotonin receptors, which is the thinking around why it has less movement side effects. Because in case you didn't know, there's other antipsychotics that have movement side effects. They're called extrapyramidal symptoms. And for the medical students watching, you got to know these. It's the tardive dyskinesia, Parkinsonism with the hypertonia and the cogwheeling, where they feel stiff as a board, the dystonia, with the muscle spasm, and the akathisia, the need to move, the inner restlessness. So those are the kind of common symptoms that you don't get with clozapine that you might get with other antipsychotics. And it also binds to a bunch of other receptors. So name your neurotransmitter, it can probably bind to that receptor. So it has glutaminergic activity, anticholinergic activity, but also some cholinergic activity. It also has NMDA receptor properties. And one thing I don't really understand in much depth is it has immunomodulatory properties. So it actually affects your immune system response in the brain that's a bit beyond me. But the point is, we don't fully understand how it works. We just know it works really, really well. The key things it does that works well is it reduces psychotic positive symptoms. So things like auditory hallucinations, hearing voices, hearing mumbling, hearing command hallucinations telling you to do things. It reduces delusions. So people having fixed and false beliefs, like they're being followed, like someone's going to kill them in the next minute, like they're being, or like they've got, chips implanted in their heads that are monitoring their thoughts and things like that. It also works pretty well for the negative symptoms, which a lot of other antipsychotics don't really touch on, because they're really hard to treat negative symptoms. If you haven't heard of negative symptoms, these are symptoms of psychosis where there's an absence of things, absence of motivation, absence of thought. So literally they'll just have empty thought times, and people can just sit or lie in bed all day. These are some of the negative symptoms you see. So clozapine can help a little bit with that. And other than the antipsychotic elements of it, it's anti-aggressive and anti-suicidal. Right? Aggression is kind of anger towards the outside, and suicidal behavior is kind of anger towards the inside. So it reduces suicide in people who have treatment-resistant schizophrenia and treatment-resistant depression and all those things I mentioned before. But it comes at a price. And so, yes, I've been telling you how good clozapine is, but now it's time to tell you the not so good side of clozapine. Clozapine has side effects. Yes, because it's so effective, it comes with side effects. And they can be split into two categories. There's the common ones and the really rare ones. But the really rare ones can be life-threatening if they're not picked up on early. And that is why there is very stringent, intensive monitoring when you start clozapine. At the end of the video, we'll talk about what it's like to start clozapine. But for now, I'm just going to talk through all of the different side effects that you need to know. And so the most famous one, rare as it is, but life-threatening if it occurs, is neutropenia and agranulocytosis. Those two words are kind of on a spectrum, and what it means is the neutrophil count goes down. Now, why does it happen? I think I'm just going to geek out right now and go full science here. So you don't need to understand this, but I only learned about this this week, and a lot of other doctors don't know about this. So it's really cool. Let's do the science. So if you actually look at this screen on Wikipedia, you can see the clozapine molecule here. Now, this is the clozapine molecule. How does clozapine get metabolized? The medical students, you should know this. It's the CYP1A2 enzyme in hepatocytes. So it's in the liver. The liver metabolizes clozapine. And what does CYP1A2 do? It demethylates. It removes a methyl group, CH4. So this is just two ways that it's this is the same clozapine structure, just one's an animation, one's a line structure. So it removes this group here, okay? It removes these four here. That's a carbon and 3 hydrogens. When that gets removed, there is a moment of time where there's nothing there except for the electrons in this bond, right? So there's a free electron pair. It's a valent electron pair. So they have, they're very reactive. And so what happens is you get a nitranium ion, where you have basically free electrons that will bind to anything that's around. And the thinking here is that they bind to proteins or something in neutrophils that damages the neutrophils and kill the neutrophils. It's either that they cause direct toxicity through denaturing proteins or something very important in neutrophils, or that they cause a hapten mediated immune response. So a hapten, this is for the med students. A hapten is when the protein or chemical like clozapine binds to a antibody, and then it is expressed on the cell surface and mediates a cell-mediated cytotoxic response type 4 hypersensitivity reaction. Ugh, what a big dump that was. But the point is, these are the two mechanisms in which we think the clozapine causes agranulocytosis. Super interesting. But why some people get it and other people's don't, we don't know. And it's only 99+% of people will never have this. Okay, it's less than 1% who will experience this. And why is that? We don't know. There are people right now in labs trying to work out if there's a genetic element, and there's some very hopeful researchers out there. So it might be a genetic thing, and if it is, then that's great, because there'll be genetic testing to predict who will get it, and then maybe the monitoring can be less stringent, because we'll talk about that at the end. So this is the thing that is the reason that people need to get so many frequent blood tests while they start clozapine. but we won't go through all the monitoring right now. Let's keep going in the side effects. The next side effect to know about is myocarditis, which is essentially inflammation of the heart muscles. And I guess the key takeaway for myocarditis, if you're a healthcare professional or not, if you're someone taking clozapine, is to know that the most common symptom is not chest pain. All right, let that sit in. And this is why we do our blood tests to pick up, like we do troponins on the blood test, which is a cardiac enzyme which shows us if there's any myocarditis happening. It indicates if there could be myocarditis happening, just to clarify. But myocarditis, common symptoms is actually just feeling like crap. It's general malaise, fever-like symptoms. So if you ever have a fever while you're starting clozapine, or if you're on clozapine, you need to get an urgent medical review. Because fevers can mean agranulocytosis and an immunocompromised state getting an infection, or it can mean myocarditis. You're feeling like crap. You're feeling lethargic. You're feeling flu-like. It's really bad to get myocarditis. That's the other thing. We also do monitoring with the ECG to pick up on this, because you can see changes on the ECG. Now, those are the two rare side effects that people taking clozapine need to know about. But let's also talk about the common side effects that kind of really affect compliance with clozapine and can ruin people's lives if they're not, on top of them. So the first one that people are usually a little bit embarrassed about is hypersalivation. So it makes people drool, especially at night when they're going to sleep and they wake up with pillows that are drenched. So a couple of things. There are ways to reduce this. First, you can get specialized pillows. They're called Clozapine pillows. Look them up on Google or ask your Clozapine Clinic if they have any. And they're either waterproofed or they're like towel-like absorbent. And the second thing is you can ask your doctor for different strategies with medications. So there are atropine drops or hyoscine tablets. Not tablets, lozenges that dry up your mouth. And so these help reduce hypersalivation. It doesn't fully eliminate it. And the weird thing is, it's not dose dependent. It's not like reducing clozapine makes you salivate less, and it's impossible to predict who's gonna get it because not everyone has hypersalivation. Some people are on 900 milligrams of clozapine with a dry mouth, and others are on 150 milligrams of clozapine, and it's just it's a bloody fountain. The reason this happens, it's probably a mix of reasons. There's a cholinergic element to the medicine, and there's also a lack of swallowing that occurs overnight when you're sleeping. So it's probably a mix of both. All right, the next common side effect, sedation. Yes, all antipsychotics can sedate, and this is no exception. So, the ways to address that is dose responsive. So you work with your doctor to find the optimal dose for you and the optimal time to take your dose. So if you're taking your dose at midnight and you're waking up groggy, no wonder. Like, take it early, take it at 7, and then usually it's a bit better by the time you need to get up. It's worth noting though that coffee doesn't fix this. So I've met people who are smashing 10 coffees in the morning to try and beat the sedation from antipsychotics. Caffeine ain't gonna fix the sedation from antipsychotics, guys. You got to work with your doctors to find the right treatment for you. And there's probably a bit of acceptance that needs, like, realistically, you need to accept there will be just some sedation with these medicines, but it's better than being psychotic. Anyway, easy for me to say. So the next side effect to talk about is this is the most common. It's weight gain. All right, weight gain. People can get fat on clozapine if you're not really careful. When you start on clozapine, you are starting on daily gym and a healthy diet for the rest of your life. If you aren't ready for that, you need to really think. You need to be careful, because clozapine will make you eat more than you should, and then you grow and you get diabetes and all the rest of it. So I hope that one message is clear, is that if you're going to start clozapine, you need to get into the mentality that you're going to do lots of exercise and eat like healthy foods. You're going to eat more than you want. I don't know how to prevent that, but hopefully just choose healthier foods. People just crave greasy food when they're on antipsychotics. I don't know why. No, like, I've looked into the research and it's just not really clear why this happens. But you just gotta do lots of exercise and eat as healthy as you possibly can, because it's so common. A really cool thing about clozapine, though, is that there is not much EPSE or movement side effects. And in fact, if people have had tardive dyskinesia where their mouth moves involuntarily because of other medicines that they take, clozapine's a great alternative because it actually reduces tardive dyskinesia. All right, guys, it's time to talk about the monitoring. And if you've made it till now, good on you, because this is the most important part, but also the hardest part to talk about. It's really a tough medicine to start, but once you've started, it's much more realistic. So usually it's started as an inpatient, and you start at very small doses, less than a tenth of what you will end up on. You start on, so it's 12.5 milligrams, then 25, then 50, and it builds up slowly over the days, and it's an oral tablet, obviously. So it's important they come into an inpatient so that they can do that slow increase in medicines, but also so that they can do all the monitoring. So in terms of the monitoring, before you start the medicine, you're going to get a full set of bloods, including your like cholesterol levels, but then all the other bloods, including your red blood cells, your electrolytes, your liver function, your kidney function, like iron studies is a good idea, and hematinics like B12 folate. They're all good ideas to start off before you start on clozapine. I guess it's important to know that there are different protocols in different countries, and in different states. So in my state, I use something called the ECPMS system, which is the Clozaril company's system. And Clozaril is a type of clozapine. It's the brand name for one of the clozapines, and this is their guidelines. Like this is 2 pages per sheet, and there's like 30 pages. So it's like 100 pages, and it tells you all the monitoring that the doctors have to do. It's usually freely available if you email the company or ask your doctor. You can probably read it. I wouldn't have any problems with someone reading theirs. And so all the blood tests, you need to get an ECG where they look at your heart electrical pathways. You need to get a echocardiogram where they look at your heart with an ultrasound. And I think that's about it before starting. But then you need to get blood tests, and you need to get weekly blood tests. And this is variable across the world, but in where we are, it's weekly blood tests for 16 weeks. Sorry, correction, for 18 weeks here. And then it goes to monthly after 18 weeks, because after 18 weeks, it's really unlikely that you get the myocarditis or the neutropenia, which we talked about earlier. And listen, this is where you make the point around compliance. This is where I should talk about compliance, sorry. If you stop clozapine for 72 hours, 3 days, you have to restart all of this. So if you've been taking clozapine for months or years, please don't just forget your dose for 3 days in a row. Go to the hospital if you need to. They'll give you a dose. They'll sort it out, because if you miss 3 days of clozapine, again, this depends on where you are in the world. In Australia, you have to restart the whole monitoring process again. And yes, some people can do it in the community, but most of the time it means you have to go into hospital to do it as an inpatient, so that they can do all the regular, thorough monitoring. And after you finish that really intense kind of 18 weeks of blood tests every week, you can go to monthly, and you join what's called a Clozapine Clinic, where you see a clozapine nurse or doctor once a month for the rest of your life. So look, it is a intense regime, but it is such an effective medicine that it's worth the price you pay in terms of the monitoring. In fact, people think that going regularly to see the nurse/doctor keeps the engagement up, which actually keeps people well, because then the nurse or the doctor will pick up if there's any kind of symptoms. Now, there are moves and then people talking about making the monitoring of clozapine less stringent because of how good a medicine it is and how rare the kind of neutropenia is. It's kind of unfair to kind of require such intense monitoring for people who, there's a lot of people who aren't on clozapine because they can't meet the monitoring requirements, and those people are being done a disservice because of essentially fear that they might get neutropenia that's missed. But my view, my personal opinion, and remember, I'm a doctor in training, I'm not a psychiatrist, and you need to talk to your psychiatrist about their opinion before you take any of these medicines, obviously. But my opinion is the risk should, we should promote people's autonomy in assessing risk, and it should be up to the patient to accept or not accept risk with monitoring requirements. So if they choose to do it every 3 months and they understand that comes at an increased risk of getting, neutropenia, then we should, that's an important thing for the doctors to appreciate. That being said, I've seen a lot of neutropenia. I've never seen anyone die from it because we always pick it up so early with these regular blood tests. So maybe my opinion would change if I saw someone become really unwell with it. All right, guys, that is it for this video. I hope that was useful. My conclusion is that clozapine is an extremely effective medicine for people who have not responded to other antipsychotics. If I had schizophrenia, I would take clozapine. That's what I would want because of how effective it is and how it changes people's lives. The key thing is just keep that compliance going. Just take the bloody medicine. I know it's not perfect. I know there are side effects. I know it sucks, but it's better than the alternative. And if you want to stop, just talk to your doctor first. Always talk to your bloody doctor first, guys. That's my advice. I wish you all an absolutely beautiful day, and I'll see you in the next video. All right. Bye for now.